So, hello everybody. We'll just wait. Hello everybody. We'll just wait for people to be able to join. And I think we can start. I'm hoping that you're able to join. I can see people coming in. Oh, hello everybody. Now I can see now I can see attendees coming in. We'll just give it a little minute for people to join. Okay, great. Good afternoon or good morning, wherever you're joining from. My name is Tanya Khara. I'm one of the technical directors from the Emergency Nutrition Network. Welcome to this session. We're going to have two sections in this session. First, 20 minutes, I'm going to discuss risk. And we'll have some time for Q&A within that. And then I will hand over to Colleen, Emary and Sarah Bowler, who will be talking about nurturing care. So that will be the second half of this session. So I'm going to start, as I said, I'm one of the technical directors at ENN, and my involvement with CMAM goes back to 20 years ago when I was part of the VALID team working on the development of the approach. But today I'm going to be talking about giving some perspectives on risk based on the work of the Wasting and Stunting Technical Interest Group that I have been coordinating since 2014. Next slide, please. So the group, as I said, was set up in 2014. It's a group of experts that were put together by ENN really to look at the question of what is the relationship between wasting and stunting. And it's a project that's been going since then, further exploring this question. We've been lucky enough to be funded by USAID and by Irish Aid. And so I'm going to be presenting a few perspectives that come out of the work of this group in our exploration of the relationship between wasting and stunting, which we started off by reviewing evidence to look at that relationship. But some of the findings that have come out of the work sort of led us to challenge some of our assumptions about mortality risk and treatment. So I want to touch on the highlights of that. Next slide, please. I just wanted to start with this public health perspective, which is, I think, a good premise behind any discussion we have about treatment. That at the tip of this triangle is the prevention of death, and how that relates to our ability to treat children, to take them out of that very high risk group, and really to hone down on those most at risk if we are going to achieve coverage of a manageable caseload and within stretched systems, as we know many of the systems we work through are. Next slide, please. So when the Wasting and Stunting Technical Interest Group started looking at the evidence around the relationship between wasting and stunting, one of the most striking findings that we came across in the literature was this very elevated risk of death that came from children being both wasted and stunted at the same time. And this was an analysis that had been done on multiple cohort data from 10 African Asian countries, where we were able to see risk of death for untreated children. And just to note, this was a pattern that was seen at any level of wasting and stunting together. And it's a similar level of risk of death that we find with severe wasting. So we found this quite a striking finding. It's also not a new finding. When we look back to the literature in 1974, Professor Waterlow had highlighted the fact that children who were both wasted and stunted were at most risk. Next slide, please. And there's many of these children. We looked into the national level data to get a picture of the numbers of children who are experiencing both these deficits at the same time. In 9 of the countries of an analysis we did of 84 countries, the levels were over 5% of under 5s were experiencing both deficits at the same time. And then a GNR Global Nutrition Report analysis estimated there were 16 million children globally. And so the question, of course, then came, well, are we reaching these children? And we realized that key to that was to really go back to the measures that we're using to identify children and see how well we are identifying risk of dying, given that our attention had been focused on this not new group, but a group that hadn't really been focused on before, of children who were both wasted and stunted. Next slide, please. So in order to do that, we realized we needed to go back to data where we could see what happened to children when they weren't being treated. So what was the level of risk associated with different anthropometric deficits? And so this is data from Senegal, which we were able to access through one of the members of the Wasting Stunting Technical Interest Group. And it represents deaths within this cohort based on what the measurement, the anthropometric measurement was, and then death within a 6-month period after the measurement was taken. And what this shows, if you think of the numbers of children that died, it shows that to some extent, these children who are both wasted and stunted, those that were most likely to die, if we're using a MUAC measure, and this is a MUAC of 115, as according to WHO standards, to some extent we have been capturing those children. But what it also shows is that there's many that we were not, and that we looked at our weight for height measure, so that's severely low weight for height, but we also looked at weight for age. And what this analysis indicates is that weight for age offers something different in terms of ability to identify children at most risk of dying that our other measures were not picking up. We've repeated this analysis now within the group on 11 other treated children, and we're finding a very similar pattern. Again, not something that's new. If we look back to literature from 1994 from Pelletier, there are similar findings around the use of weight for age for identifying risk of death. Next slide, please. So obviously, when we're looking at caseload of children, this finding that there's another group of high-risk children that aren't picked up by that those severe measures that we have been using. There's questions about that, of course, in terms of how able our systems are to reach more children. And really, to look at this, we realised we have to look into the data to see whether our intensity of the same intensity of treatment is needed or not. If we look by levels of risk, perhaps those levels of risk that are less severe, that are not the highest levels of risk within this cohort of high risk children, may be able to be treated with less intensive methods. And so we've tried to look at this with the analysis. And what we see is those children who just have the severely low weight for age, they are at high risk, but not as much risk as the low MUEC children. And so perhaps there's an opportunity there to have less intensive treatment, and that would allow that treatment to be delivered through more community-based platforms. So there's an opportunity there. But we wanted to test this and find out really what that additional group of children needed. And a study to test that's been designed by the group. Due to the current context with COVID, it hasn't been possible to put that into implementation as yet, but it's still something that we would like to be able to do. Next slide, please. So I was asked to pull out what some of the really practical implications of this work is. In some ways, it requires a different thinking about things, and I think one of the key implications is that if we want to support coverage of those most at-risk children, it may help us to frame our research and our programming by levels of risk and explore the intensity of treatment required at those different levels of risk. So beyond just seeing a SAM and MAM categories, which I'm sure has also been explored in other sessions during this conference. And that this may be able to assist us with those issues of cost and overburden of health systems, and capitalize on alternative community-based platforms where less intensive treatment could be possible. The other implication is this opportunity that these findings offer in countries where growth monitoring and promotion is being practiced and still widespread, that may offer a platform for identifying children at high risk using weight for age. Next slide, please. Okay. There were a couple of other highlights from the work that I just of the Wasting Stunting Technical Interest Group that I also wanted to highlight, because I think they refocus our attention on prevention. Firstly, that wasting and stunting share common drivers, and that children experiencing wasting are left, it seems, more likely to experience subsequent stunting. Also, we found from looking at cohort data that our treatment doesn't reverse all the impacts. It leaves children more vulnerable to additional periods of wasting and, as I've said, also to longer term stunting. Also, the wider evidence is really pointing us towards those initial months. And I know a lot has been discussed already about the MAMI work and the focus on children less than 6 months. That a similar message is coming out of the work looking at the relationship between wasting and stunting. And that really, if we need to prevent this accumulation of vulnerabilities that can happen that lead to more wasting, more stunting. And so, of course, points towards as well the importance of those initial months, points towards maternal and adolescent nutrition. So I just wanted to finish, next slide please, by coming back to this pyramid and the importance of preventing wasting. and this cycle of vulnerabilities that it can lead to, and the opportunities that looking at wasting and stunting alongside each other give when we're talking about prevention, both in terms of perhaps financing efficiencies, if we're looking at the both of them together. And if we want to achieve coverage for that red part of the triangle, that we have to come back to this question of preventing large numbers of children getting there. And my final reflection is just, I was recalling that early on in the development of CMAM, a wise person said to me, don't leave prevention behind. And at the time, I think my response was, well, we can't move as fast as the slowest horse. But actually, when these elements are so connected, I think now my reflection 20 years on is that we have to attend to that horse, or we will not be able to progress further in our objective of achieving coverage for those most at risk. So this is an area that now at ENN we are trying to focus more on. Next slide, please. Really consolidating what we know on wasting prevention in the wider context of prevention of undernutrition. And particularly we'd be really interested to hear from countries trying to grapple with that question. So thank you. If you want to see the work of the Wasting Stunting Technical Interest Group that I've given some highlights of, please look at our website. Also, if you are working at country level, district level, and have some interesting experiences to share in trying to tackle wasting prevention, please get in touch. If you have data that you feel would contribute to this, to better understanding the relationship between wasting and stunting, please get in touch. And particularly if you're interested in collaborating on the use of trialing the use of weight for age alongside MUAC within CMAM, do get in touch with me. So I think there's no questions. I don't know if that's a good or bad sign, but I will hand over to Sarah, and if any questions do come up, do put them in the chat and we can come back to them perhaps at the end if there's time. Thank you.
Thanks so much, Tanya. That was a great presentation. My name is Sarah Bowler, and I am a Senior Advisor for World Vision International. I work in the area of design, monitoring, and evaluation and research in nutrition. And I'm joined today by my colleague, Colleen Emary, who is a Senior Advisor in nutrition for World Vision's Technical Service Unit. So we're really excited to be with you today. We're going to be sharing about nurturing care in prevention and treatment of malnutrition. And if you have any questions, please do not hesitate to post them in the chat. Next slide, please. So for our presentation, we're first going to cover what is nurturing care and why it's important, and how caregiver mental health impacts child care practices and growth outcomes. We will also describe 3 evidence-based approaches and models to implement nurturing care in health and nutrition programming. These project models include nurturing care groups, community health worker programming, and then finally early childhood development and CMAM. Next slide, please. So let's begin. So what is nurturing care? According to WHO's Nurturing Care Framework, nurturing care refers to the conditions created by public policies, programs, and services. These conditions enable communities and caregivers to ensure children's good health and nutrition and to protect children from threats. Nurturing care also means interacting with young children in a way that is responsive and emotionally supportive. And I'm going to talk a little bit more about that in the next few slides. The WHO framework includes 5 components of nurturing care: adequate nutrition, responsive caregiving, security and safety, opportunities for learning, and good health. Most importantly for us at World Vision, we've taken this nurturing care framework and we've moved us from a survival or a child survival agenda to a child thrive agenda. So we really are focused more on helping children thrive, not only survive. Next slide, please. So I'd like to spend just a few minutes on some of the nurturing care and child health outcome findings. So first, the period from pregnancy to age 3 lays the foundations for health and well-being. This is where in a baby's brain, 80% of the baby's brain is formed during this period, and there's long-term effects for productivity and for learning. Poverty, insecurity, gender inequalities, violence, environmental toxins, and poor caregiver mental health reduce the capacity of a caregivers to provide nurturing care. And in the next few slides, I'm going to share more, especially about caregiver mental health. For every $1 spent on childhood development interventions, the return on investment is as high as $13. And the cost of children who do not receive nurturing care is high. In low to middle income countries, more than 4 in every 10 children risk these critical development milestones due to poverty and poor nutrition outcomes. Next slide, please. So why is addressing maternal mental health so important in promoting nurturing care? Well, depression is a major unaddressed problem in most of the countries we work. Post-traumatic stress disorders and other mental health problems are a leading health issue in fragile communities, especially among female adolescents and young mothers. We just conducted a symposium within World Vision around adolescent mental health. Globally, the prevalence of maternal depression ranges from 15 to 57%, depending on the study, and women are more than 2 times likely to suffer from depression than men. Emerging evidence has found that the prevalence of depression among mothers of wasted children are markedly higher than mothers of non-wasted children. And depression is a significant burden among mothers with children hospitalized for severe wasting. Postnatal depression also has a significant negative impact on breastfeeding practices, especially in regards to the duration or how long a mother breastfeeds. Infants of mothers with depressive symptoms have a 2.2 higher odds of being stunted than infants of mothers with few depressive symptoms. Next slide, please. There is also a growing body of evidence that is helping us better understand maternal mental health and its impact on newborn and child health outcomes. Maternal depression exposes children to violence, and distressed and anxious women are less likely to care for themselves. And in low resource settings, maternal depression is directly linked to, and I'm going to just share what these are, higher rates of preterm birth, low birth weight, and restricted fetal growth, early cessation of breastfeeding or stopping breastfeeding, higher rates of stunting, especially in the first year of life, higher rates of diarrheal diseases, and lower completion of recommended child immunizations. Next slide, please. So quickly, I just don't have time to go into much detail about this, but I also think it's important to understand the consequences of maternal depression on child well-being and cognitive growth. So research has found that infants of prenatal depressed mothers showed greater growth retardation than controls, and children of mothers who are depressed in the early years may suffer lasting effects on their brain architecture. Maternal depression also negatively impacts a child's cognitive development and also can lead to behavioral difficulties. Next slide, please. So now we get to the exciting part. How can we address some of the issues that I've raised? We would like to cover, with the remaining time, 3 evidence-based approaches that World Vision is implementing. So the first that I'm going to cover is nurturing care groups, and then my colleague Colleen will cover the second 2. Next slide, please. And next slide, please. Okay, great. Thank you. So World Vision has taken the care group approach for household level behavior change, and we've adapted it to WHO's multi-sectoral nurturing care framework. So the purpose of this adaptation is to move us to a Thrive agenda, and to promote the adoption of nurturing care key behaviors. We believe this approach will help us better address violence against children, adolescent nutrition, caregiver mental health, child injuries, and early childhood stimulation and development. Next slide, please. So just really quickly, this is a nurturing care group model. I'm sure many of you have seen this. I don't have time to go into much detail, but it's a cascading approach that consists of 10 to 15 community-based volunteer health educators who regularly meet with project staff for training and supervision. Each volunteer then regularly meets with 10 or 15 neighbors, and they're able to promote key messages to these households. So essentially, the care group or the nurturing care group model is a multiplying effect to equitably reach the most vulnerable households with desired interpersonal behavior change communication. Next slide, please. So World Vision, along with Food for the Hungry, Columbia University and Johns Hopkins University, took the care group approach, and we integrated this with IPTG. IPTG stands with Interpersonal Psychotherapy for Groups. And we conducted a randomized control trial of 1,200 depressed mothers in Kitgum, Uganda. We studied the impact of 3 months of weekly depression treatment with IPTG within the care group approach for behavior change on maternal depression outcomes and for adoption of caregiver health and nutrition and WASH behaviors. And I've just included 2 of these key findings in this slide. So the first is that women participating in care groups treated with IPTG had a greater reduction of depression, around 25% than in the control groups. And then women who were no longer depressed after treatment had adoption rates that were 39% points better than still depressed women on 12 behaviors that we were promoting. And those 12 behaviors had to do with infant and young child feeding practices and also WASH and essential hygiene actions. And then quickly, right before I turn it over to Colleen, we're also working with Food for the Hungry. We're taking our nurturing care group model and integrating it with WHO's problem management guidelines to address maternal anxiety, stress, and depression. And we hope to pilot this new module in the next few months. So I'm going to pass it on to Colleen.
Thanks very much, Sarah. So now we're going to touch briefly on another model of programming that we've used to implement the concepts of nurturing care, CHWs. Next slide, please. So World Vision, along with the Ministry of Health in Ghana and the 1 Million CHW campaign, developed a CHW package based on the nurturing care framework. So this CHW guideline included the promotion of certain elements of the nurturing care framework that you can see from this slide. So during the home visits, the CHW would touch on each of these points over a period of time. So while this package of materials and this guideline was initiated in Ghana, it has been taken up by Ministries of Health in a whole bunch of other places, as you can see from this slide. Next slide, please. A fundamental part of this curriculum is that it is based on a promote, protect, and treat framework. So this is a little bit similar to what Tanya shared us earlier, but it's not in the pyramid shape. So the idea behind this promote, protect, treat framework is that you are targeting the most vulnerable families with certain supports and measures. So what this involves is the community health worker conducts a household assessment along with the family to identify those that are at higher need. And then rather than all households getting the same package of interventions at the same way or in the same way and at the same time, there's a more targeted approach and a more targeted package of services given to those households that have the highest needs. Next slide, please. So under the first element, this would be the package of services that are provided to all families. So on the right-hand side of the slide here, it just shows some of the elements that are covered in this CHW guideline. So it's a timed and targeted approach. So you're reaching households between birth and 2 years of age and you're timing when you meet them with what you give them. So for example, it's a storytelling approach as well. It really promotes engagement of fathers. The idea is to promote a house or child-friendly home and to teach caregivers on how to engage and how to play with their child according to the age and stage of their child. It's also to raise awareness about the impacts of violence, abuse, caregiver mental health, and how that affects the child and affects the whole family. Next slide, please. So under the next part of the framework, this would be targeting families that have been flagged or identified when that household assessment was done. And then there's more intensive supports given. So for example, under this yellow group of households would be identifying caregivers that perhaps there's some mental health needs or additional supports needed for that family. So in response to this, the recommendation is that the CHW visit those families more often, and when the CHW visit, they're going to be addressing the issues that were identified earlier. Next slide, please. So under the third, this is your most intensive level of support. So these are your families that are at highest risk. For example, maybe it's a family that has a low birth weight infant, so there'll be additional support and care around kangaroo mother care, for example. With respect to child growth, so a child that has been identified as wasted, for example, they would be flagged under this treat paradigm. Next slide, please. And part of this CHW curriculum includes this root cause approach for those families. So let's say a child has been identified, maybe they have low MUAC, low weight for height, or maybe they are, those are, they'd be flagged that way. So the community health worker will do a root cause assessment with that family to identify what are the issues going on in that household. And this root cause assessment looks at, as you can see on the left-hand side of the slide, looks at a bunch of different causes. So looks at issues related to household food availability and diet, things related to agriculture supports. What's the wash environment like? And with that, they come up with a plan. And the idea is that we're not going to be treating these children and then returning them back to the same household environment. Next slide, please. So I'm moving from onto a new program. Sorry, I'm going a little bit quickly here so we can get through this last intervention. But just regarding that package of interventions for CHWs, it is available, and there is the URL on the previous slide. Now, just want to switch gears a little bit and talk about ECD in relation to CMAM. Next slide, please. So I just wanted to describe briefly a program that we implemented. So this was a WFP supported program, and it included a blanket supplementary feeding program and a targeted supplementary feeding program. And in addition to that, we implemented a parenting program. Next slide, please. So this was based on World Vision's program model called Go Baby Go. Next slide, please. So what did the intervention entail? Well, it involved working with the caregivers, meeting with the caregivers in small groups while they were at the actual SFP site. And so there was a trained worker who had learned about the Go Baby Go program, had been trained in it, and provided small group sessions for mothers as they waited. So this included also practical exercises like making toys. And then in addition, that worker would visit the homes once a month. Next slide, please. So it was a 6-month intervention. And what we did is each month they would have the small group sessions and then home visits. And so we looked at treatment outcomes, comparing the standard of care. So we had a group that in the intervention area that did not have the Go Baby Go intervention, and a group that did. And so when we look at treatment outcomes, this is just one aspect, but we did show that combining CMAM with the Go Baby Go seemed to result in those sites that had the intervention, their outcomes were better, just in terms of treatment. Now, understanding why, that's something we need to look more into, but it could perhaps be that even offering those sessions proved to encourage mothers to bring their children, so there was more regular, there's less children dropping out, sort of thing. But I think what this first study showed us in Sudan is that it is feasible to implement this package of care alongside a standard CMAM program. Next slide, please. So just wrapping up here, I hope, I know that was a really quick overview of some of these interventions, but I hope we did leave you with a taste of just some of the examples of ways that we can include these components in our field work. And as Sarah said, really, we need to move beyond this agenda of treating children, looking at survival, and more to thrive. So if you have any more questions about what we presented today, we'd be happy to follow up with you. Thank you very much. And I think we're almost at the end of time. But let's see if there are any questions for either Tanya or Sarah and myself. Thank you. Oh, so we have 5 to 10 minutes left for questions. So let's have a look here. Tanya, do you have some that are waiting for you to answer?
Thanks, Colleen. I answered a couple in the chat, but then I realized I'm not sure if I answered them in the right place. So I don't know whether I should just sort of repeat that. Or do you, if you have some questions to answer, do you have any to answer?
I could answer one quick question. Oh, you go ahead, Colleen. You go first.
No, I was going to read the one out regarding IPTG, Sarah, so go ahead.
Yeah, that was the question I was going to answer. There's a few questions around IPTG and breastfeeding. So yes, absolutely. Breastfeeding can be a mitigating factor, or a very low cost, easily scaled intervention that we can promote as a preventative measure against depression. So when a mother is breastfeeding, she releases the hormone oxytocin. And oxytocin, this hormone, has been found to protect against postnatal depression. So I think that this is something that we can explore more in our programming, but there's also, I think, an evidence base around promoting breastfeeding is not only good for physical health, but it's also good for the mental health of both the mother and the child. I'll let you go ahead, Tanya and Colleen.
Okay, I see one here. Sorry, it just jumped on my screen. Let me just find it again. It was regarding Ghana and the CHW programming. So did the CHWs in Ghana feel able to take on the package of interventions within their current workload remuneration, or did this require additional resources for CHW time, financial incentive? So yeah, great question. And I know that in Ghana and in these other countries where they have revised their CHW package of work, kind of part of that process has been looking at what their workload is, doing an analysis of what their workload is. And then there has been a lot of advocacy to make sure there is appropriate incentives, appropriate payments for CHWs. Now, I wasn't specifically involved in the Ghana work myself, so I cannot unpack the details of that for you. But if you want to follow up with me, I can connect you with colleagues that know more of that background. But just to say, as part of as this curriculum has been updated, looking at workload is certainly part of that, because it's not possible, right? We already know CHWs are overburdened, so there needs to be that workload analysis done as part of the as part of the planning and work.
I think there's a follow-up question that I can answer if we've got time, which is just around the use of weight for age, and that obviously with using that CAD classification, you can end up including children who are not wasted but only stunted, and this is an area that we're very interested to try and pick apart, and we've been doing some analysis with data from some of the combined protocols, looking at those weight for age children and how they respond to treatment, and how, because obviously if it's the weight that's what we're looking for is their weight to be recovering. There is that concern, okay, if this child is low weight for age because they're extremely stunted and there's no level of wasting, what are we doing when we supplement them? And that would be something we would be looking at in depth within the study, ensuring that it is their level of wastedness that we are having an effect on, rather than this question that comes up about overfeeding, or setting us up for problems later on in terms of NCD risk. So those are all really valid questions, but things we would want to be looking at as part of the study of how we might incorporate weight for age into CMAM programming.
And I see, thank you, Tanya. I see another great question about stigmatization and mental health. And so, yes, this is an incredible issue that we face, not only in low to middle income countries, but also in high income countries. It's a global issue. So even in some cultures, there aren't words in the local language or vocabulary to describe depression or to describe some of the feelings that we would normally use for depression. I will say, for one of the important parts for any sort of intervention that is addressing this is to identify health services, mental health services that can treat or care women who are found to be severely depressed. So you do have to refer those women that are severely depressed and who may have a plan in place for suicide. So for women who are moderately depressed or mildly depressed, we have used some of these, like the Problem Management Plus or IPTG approach within World Vision to address mild and moderate depression. We've also worked with faith leaders. That's been a huge component and strategy within World Vision, being a faith organization. We've worked with Muslim and Christian and all faith leaders in our communities to educate and destigmatize mental health. And that's been a very effective strategy. And then also just sensitizing health care workers themselves and helping them better understand symptoms or signs of mental health, and encouraging that some of these issues and ways of addressing this can be better integrated within the healthcare system. So by no means have we reached, destigmatizing mental health everywhere. This is an ongoing issue that we're going to face for many years to come. But I think that we're seeing hope, and there's exciting work that's being done, and a growing I think, intentional understanding of mental health. So it's moving in a positive direction.
Okay. I want to
go ahead.
Yeah, I wonder if I could just say something about. So we have one of the questions. Let me just find it. What potential does the use of weight for age and MUAC have for settling the MUAC versus weight for height debate? And to what extent does it respond to concerns that MUAC only programming misses weight for height only kids? I think the strength of the analysis that we've been doing is that it looks at those children at most risk of dying. So it doesn't it's not looking at how one measure identifies children identified by another measure, which we've done a lot of in the past. It's really looking at how they identify those most at risk. So if we are most concerned about those weight for height children that are at most risk of dying, I think our analysis does show there's an opportunity there in that a combination of MUAC and weight for age is able to identify the children in that category who are at most risk of dying. And in some, in terms of looking at MUAC only programming, that is again the helpful lens, I think, to look at, okay, if you then raise your MUAC, are you picking up those in the weight for height category at most risk of dying? So it's a slightly different question. But yeah, I think there's definitely opportunity
Maybe I'll just take one more question, and then Tanya, I'll pass over to you to close this out. But this was regarding the ECD CMAM example I presented. So how do you explain the higher non-response in the control CMAM group? What was the definition? So the non-response was how it was defined was by the protocol in Sudan. So if a child had not reached the cured criteria within 4 months, 16 weeks, then they were exited the program as non-cured, non-response. So why did we see a higher in the standard of care group? I don't have a good answer for that, so I'm sorry to at this point. What we do wonder, and what's something we need to go back and look at the data is, did we have in that group, was it that caregivers were not coming as often, right? Were they missing more visits, that sort of thing? Whereas in the Go Baby Grow group, because there was this additional activity, did that serve as incentive to attend? So there was more regular, children were attending every time. Again, we need to unpack that a bit more, but so I don't know, basically, is the answer. So over to you, Tanya.
Thanks, Colleen. Well, thank you everybody for attending. It's slightly weird not being able to see you, but we know you're there. Thank you for the questions. And yes, I hope the rest of the conference, the rest of the day is enjoyable. Thanks, Colleen, and thanks, Sarah.
Thanks, Tanya.
Thanks, everyone. Bye-bye.